I would like to really thank Dr. Fabian Piedemonte for this fantastic congress, for inviting me here in this wonderful city. For me, it's the first time in Argentina, and I'm really impressed. Thank you. I don't speak Spanish, but I think I could understand about everything of the last speaker, and I totally agree. I think enhancement is like doping in society to interact in OCD. I was asked by Dr. Fabian Piedemonte to talk about surgery for OCD, what have we learned in the past 20 years? And then I was sitting and I said, how can I do that? And then, before continuing, I will just show a disclosure slide that I've been collaborating with Medtronic and Boston Scientific. I owned a patent, but no one never got monitored for the DBS and OCD, and there are some research plans. So I was trying to answer that question, and then I said, let's just type in PubMed, you can do it also. You see there, DBS, DBS, deep brain stimulation, OCD, obsessive compulsive disorder, and then you get a graph like this on the left side. So you see that starting in 1999, there are quite some publications on DBS for OCD. And then I focused on that year, 1999, and the thing that I saw there was this publication when we implanted electrodes in the anterior limb of the internal capsule, and the brain map is down below, for OCD, treatment refractory OCD patients that have had medication and behavioral therapy, cognitive behavioral therapy. And the idea was that we would implant the electrodes at the site where we did the capsulotomy. As you can see here, the lesions, and there are the electrodes. So, what did we do at that time? From the first patient onwards, we reduced medication, we operated, and then here is yellow. That's the time after surgery when we tried to optimize the stimulation parameters as much as we could. We thought, now we think we have it. And then we did the double-blind randomized crossover trial, on-off, or vice versa, and we followed the patients for 4 years, and then at the last follow-up, LFU stands for the last follow-up, and there was blinded evaluation in this randomized controlled trial. So, to make a long story short, this is the MyBox, Gale-Brown Obsessive Compulsive Score. It's the primary outcome that measures the obsession and compulsion. And as you can see, preoperatively, the score was above 30, so between 30 and 40. And during the on phase, there was a significant decrease. During the off phase, it raised again, so it got worse, but it did not get completely to the preoperative phase. But anyway, DBS clearly is better than no DBS. And 4 years later, those patients are still better, and at last follow-up, this is a publication, well, the first implantation we did in 1998, and this is a publication from 2015, so quite some years, and you see that most patients still are better at last follow-up. And so this was for ONC, obsession and compulsion, but the associated anxiety and depression, they also were better during the on phase, Hamilton Anxiety Rating Scale, and here Hamilton Depression Rating Scale. There is a global assessment of functioning that does the opposite, which means improvement. We did see side effects. So in 2 patients, here on top, you see patient 1 until 24, and patient 11 and 12, we had a hemorrhage. So you should know that to mimic that lesion, huge lesion, anterior capsulotomy, the DBS electrode was not big enough. So we had to take spinal cord lead, but the tip was bent. And Medtronic was not able to make it unbent. The surgeon had to do that himself, but then with a straight stylet. But in those two patients, there was a deviation because it was not perfectly straight. And we could not convince Medtronic to make it unbent. But after those two hemorrhages, they made it unbent. So we have suicide attempts in three patients here. But most patients had suicide attempts before surgery. So this was actually an improvement. And then there are some epileptic seizures, but we never saw changes in the EEG. So where were the electrodes implanted? Those black dots, these are actually the active contacts at the moment of best effect. And so the quadrangles and the stars mean the places of the electrodes in patients that had at least a 35% improvement in vitals. And what we found was that the electrodes that were in the Beta-nucleostia terminalis showed the best results. Then there was a separate group in Amsterdam, that's the country next to us, with Damian Denis as the psychiatrist, with Schuurman as the neurosurgeon. They did similar things, but the electrode they implanted just a little bit anterior to the BNST, that nucleostia terminalis. It was in the nucleus accumbens. But to go there, to higher structure, you pass the anterior nucleus. So, and what did they see? Similar things. This is before surgery, and then you see the white box measure for obsession and compulsion decrease, and when the battery is empty, it increases again. And same for anxiety and depression. And they also saw some side effects, like 3 patients, this is in 16 patients in total. In 3 patients, they saw feeling of stimulator in the chest. 1 patient felt the extension needs. 7 patients had increased libido. There were some intuition problems and forgetfulness. Okay, then there's the double-blind randomized controlled trial. This is a different target. This is STN, subthalamic hypnosis, from the group in France, where you see the white box, and there's a double-blind randomized controlled trial, as I said, and during the on phase, the white box decreases, which is improvement. During the off phase, it's high. And of course, the opposite happens with the global assessment of function. And then you have Stéphane Chaladès, who is here from France, who looked at the results at 24 months after surgery. So this is before surgery, white box. These results seem to be better at 2 years. And when you look at the white box divided into obsessions or compulsions, so both obsessions and compulsions get better. They also saw side effects. I'm looking at the permanent ones. Here on the left is transient. With permanent, there's one dysarthria, there's one heart rate related problem, and there's a diabetes type 2, which is probably unrelated. So, the question that Dr. Fabian Piedemonte asked me was, what happened in the last 20 years for surgery for OCD? So DBS is only one part of the surgery, but then there's the lesioning. So let's look what PubMed says on lesioning. So when you write lesioning, it doesn't write a good answer. So I divided it into capsulotomy and OCD. So this is 1999. So the number of publications does not decrease when you do have DBS, it really increases. So there, in general, you can say there's more interest in psychosurgery, I would say. So more publications. So let's look at the next one. Cingulotomy. and OCD. So also here there are more complications. And limbic leucotomy, also there, more complications. And subchoroidal tractotomy, also there are more complications. Of course, I cannot tell you the content of every of these publications I tried to select. But what we do know now is here's a publication of 2020, and it's a review done by the group of Ruben in Shanghai. And you see it's on 459 patients. This is a figure coming from one of the publications of the group of Dr. And so you see there are different types of lesioning. Cingulotomy, where you can see this lesion, capsulotomy, or subchoroidal tractotomy, or when you do both anterior cingulotomy and subchoroidal tractotomy, you call it limbic leucotomy. But no matter what you do, before surgery the Y-box is high, and it is significantly lower at last follow-up. So these types of surgery seem to work. How do you do this lesion procedures? The previous slide is about where, but how do you do it? Well, many people do it with radio frequency. You can do it with radio surgery, with LIT, laser interstitial thermal therapy, with magnetic resonance guided ultrasound. And for the planning, you can use anatomical targeting for chronic, even do it on chronic ones. The question is then, have we learned that DBS or lesioning is better? So there is a very nice meta-analysis by the group of the Netherlands, and this is the meta-analysis. So these are papers. Every line is a separate paper, and in the beginning it's ablation, and here below it's DBS. You see a difference? I don't. So this is the responder rate after the 12 to 16 months, and this is the responder rate. So again here, ablation versus DBS at last follow-up. So there's really no difference. But all these treatments, whether you do lesioning or whether you do DBS, they try to interact with pathways. And in the beginning, before 20 years, we didn't know really, we didn't have this nice illustration of those pathways, but nowadays we have. And so you see, these pathways go from the orbitofrontal cortex, ventrolateral prefrontal cortex, dorsal anterior cingulate cortex, and this goes to the thalamus and then the temporal brainstem. The group of Andres Hoare has published very, very nice work on these pathways. And so the interesting thing is he looked at results from 6 different centers: Cologne, Boston, Brisbane, London, Madrid, Melbourne. We are not in there, and I'm very happy. So it's completely away from our center, but we find exactly the same results. So it's not center dependent. And so what you see is that the Y-box at baseline is 29 or higher, and the improvement of the Y-box is 31% improved or higher, even up to 52% here improvement. And a lot of formulas and so forth, but here's the final result. Where is the sweet spot according to those centers? Well, on top you find here the axial slices, coronal slices in the middle, and then at the bottom sagittal slices. So the more red, the more you are in the sweet spot where the best contact should be. So what you see here is this gray is actually the fornix, and then a bit more anterior you have the anterior capsule. This is the anterior crosier, and there in between there is the sweet spot. This is the dead nucleus of the stela terminalis, and it's connected with ITP, the inferior thoracic peduncle. You know how that works. So, what you also can say is there's also a cold spot. And look where it is. It's nucleus accumbens. So, remember in the literature, the group of the Netherlands has implanted an electrode in the nucleus accumbens, but with several contacts above it, and the stimulation of the nucleus accumbens has as best target not the nucleus accumbens, but above it in the internal capsule. So that's also a confirmation of what is here. So this is a group of people. Half of this group wrote a book, and the other half was the peer review. For instance, you see Benedict in there. And which book was it? Well, Intervening in the Brain-Changing Psyche and Society, Recommendations, published in 2007 with Springer Award. And what does, I will not go through the whole book, but this book says the indication, the preoperative and postoperative follow-up need a multidisciplinary approach. The psychiatrist has a leading role. Here are psychiatrists. This is a paper of many psychiatrists, 34 international experts representing 22 countries. And they made a list of recommendations. This disorder has this treatment with level A, B, and 2. So I took one line out of these long tables in this publication, published in the World Journal of Biological Psychiatry, and it says deep brain stimulation. In the majority of studies, DBS was superior to sham. It should be restricted to carefully selected treatment refractory sufferers from OCD. This is level A of evidence, and these are psychiatrists that say it. Neurosurgeons, we know they are quite positive about this treatment. And then there's a paper here in Nature Medicine in 2002 by Vera Vis-van-der-Wallen and others. Several of them are here. And look at the title, Deep Brain Stimulation for OCD. It is an effective treatment for OCD. So in that paper, we say it is effective, it's an established treatment, and that's based on these 6 randomized controlled trials. So what we can say with regard to DBS is that DBS for OCD is established, but for other psychiatric disorders, major depression, anorexia nervosa, aggression, schizophrenia, substance use disorder, but also ADHD and so forth, that is still investigation. There are trials going on, as you know. So I would like to conclude that there's the same sentence that I already said. The indication, pre and post follow-up need a multidisciplinary approach, not you alone as a neurosurgeon. The psychiatrist has a leading role. The therapies modulate relevant brain pathways, and we've looked at that. And what is established? Well, I said something about DBS for OCD. It's established when you are in the anterior implant capsule of the brain matter just below, or ESPN. But ablative procedures exist already much longer, and I think we should accept it. So, thank you very much.